viruses that, there's a coronavirus that affects enteric processes specifically, others that affect the respiratory tree and a few other systems as well. The vast majority of human coronaviruses, which I've labeled there, is the OC43229E, NL63, and the Hong Kong University 1, usually cause mild respiratory infections on a yearly basis. But in the last 2 decades, we've started seeing a rise in the severe respiratory syndromes. And the two that come to mind are SARS-CoV, which is the CoV-1, which affected about 8,000 people globally, with 800 fatalities, with a fatality rate of about 10%. And then came along the MERS virus in about 2012, which affected 857 infected people, with a much higher fatality rate of 35%. This new virus that we've come across has got quite a strange genotype as compared to the other two. The previous two seem to have had a reservoir as the bat. The human coronavirus 2 supposedly has a predilection for bat as well, but it seems to have had another intermediate host which hasn't been fully classified. There have been a few candidates that may play a role in this particular virus and the way it's developed. Also to mention that cell receptors are similar between CoV-1 and CoV-2, but MERS can also affect a separate DPP-4 receptor, the dipeptyl peptidase 4 receptor, which is found in lungs. So they can go with multiple receptor types in terms of their method of entry into cells. Generally, mild diseases, mild pneumonias with a few symptoms. The severe types are the ones that we're talking about, with dyspnea, respiratory issues, going on to needing ventilation and critical care when they get into the shock state with multi-organ failure. So this virus seems to have quite significant homology, about an 80% homology with the original CoV, but this new virus seems to have a lot more homology with the bat virus. And because of that, and because of certain changes in its non-structural proteins, as they're called, it's been reclassified as a subgenus of Sarbecovirus as compared to the CoV-1, which is not part of this group. It still belongs to the genus beta coronaviruses. When one looks at the diseases that, besides the respiratory illnesses that were caused by SARS and MERS, you find that encephalopathy is obviously very, very common, with seizures or without seizures. Neuromuscular disease, including motor neuropathies and myopathies, whereas with MERS, there was a far greater predilection for ADEM, strokes, Bickerstaff, brainstem encephalitis, and neuropathy. So slightly different, but still encompassing most of the nervous system. In terms of transmission and replication, this virus has clearly been changed in many ways since it's moved from wherever it came from, pangolin, I think. The spike protein is a very important component of the virus, and it mediates receptor binding and membrane fusion, and it usually binds to the ACE2 receptor. And most importantly, it will select host based on this. So if the host expresses the ACE2 receptor, obviously it's a perfect host. And once it's got that receptor, it'll obviously then bind to it. And this particular virus has got a 10 to 20-fold higher affinity for the human ACE receptor than the previous viruses. And also it does not use any of the other virus receptors like the aminopeptidase N or the DPP-4 receptor, as I talked about earlier. Then the human cell also plays a role in its entry, and it has various ways of cleaving the virus shell protein or envelope protein and gets into the cell based on the way it actually cleaves the S protein, which is made up of two subunits, S1 and S2, then enters the cell, does not end up becoming a DNA molecule, but rather gets replicated into a variety of new molecules. Then there are a bunch of non-structural proteins, as they call them, which actually are very important in ensuring proper transcription and translation of the virus. They then get assembled into the endoplasmic reticulum, via the Golgi, into new virus particles, and then get shed out of the cell. So they're very good at hijacking our mechanisms. And the good news is that they don't seem to make DNA copies of themselves and incorporate themselves into the human genome. What happens then is obviously the cell, the receptor of the ACE2 goes down, and with that, it pushes up a bunch of immune cells into the vicinity of the infection. Those cells then get infected, which results in lymphopenias, etc. They then trigger the immune cascade with IL-6, GM-CSF, interferon gamma, all being upregulated. This results in monocyte activation, resulting in macrophage activation and macrophage activation storm, literally, or the macrophage activating syndrome. And then all hell breaks loose. And with this dysregulated immune response, you get a hypercoagulable state, which we can talk about later. And I'm not going to go into great detail there. There's a whole bunch of mechanisms by which that happen. And that hypercoagulable state, as we know, gives rise to the vascular events, the thrombotic events in both arterial and venous trees, and obviously even translocation into the CNS. Of the first sort of registries that started looking at patients, the UK published the first 125 cases, which presented over a 3-week period. They noted that 39 patients had altered mental status, of which they classified 16 as encephalopathic, but 7 with an encephalitis. Come back to that later. 23 of their patients had a neuropsychiatric disorder, 10 with a frank overt psychosis, 6 with a dementia-like syndrome, and 4 with an affective disorder. And then quite a large number of their patients with a cerebrovascular event, of which most of them were ischemic strokes. I'm going to kind of classify and work through the more common symptoms rather than going through the major symptoms, and then kind of bring it all together later on in this talk. I'll start with anosmia and ageusia, which are probably the most common symptoms that we've seen in both asymptomatic and symptomatic patients. And the mechanism by which this happens, and it's been shown with coronaviruses and other viruses, in particular herpes viruses, where they seem to get across the cribriform plate via the olfactory nerves, where there is no real great blood-brain barrier, allowing for retrograde transmission of the virus. And it's been shown that the coronavirus can actually do that. MERS virus can also do that, and MERS seems to use a different particle, a different receptor. And then from there, the virus has the ability to transmit itself into the CNS. Influenza also uses a similar sort of a process, using the vagus nerve via the lung, and can enter the humans and become systemic in the process. From a European study that was released of a multinational group, they had 417 patients in their registry, of which 86% of their patients had anosmia and 82% manifested with gustatory dysfunctions. Now, people can argue that this can be a normal phenomenon with most respiratory infections, as though the patient develops coryza. But in this particular case, and in particular with CoV-2, which is also known as SARS-CoV-19, this phenomenon happens as an isolated phenomenon, implying that there must be direct involvement via the olfactory nerves. Then they've also lumped some of the manifestations into encephalitides and some of them into encephalopathies. I'm going to give you their criteria as to what they use to help come to this diagnosis. So the most common one were the encephalitises. And by this, they're implying that there's an inflammation of brain parenchyma, either as a direct result of the virus infecting the human brain or as an immune response to the virus. And they used clinical evidence for inflammation being pleocytosis in the CSF examination, imaging changes, and EEG changes. In terms of the onset, they seem to predate, there seems to be a predilection for the encephalitis to start sometimes before the onset of the symptoms of respiratory symptoms and as late as up to 17 days. The usual clinical picture is that of irritability, confusion, psychosis, reduced level of consciousness, and those are usually patients that may or may not manifest with seizures, and so they should be looked for actively. Other symptoms that have been documented includes ataxia, oscillopsia, hiccups, bilateral facial weakness. And most importantly, they've not been able to identify the virus RNA in the CSF in patients. Of the EEG changes that have been documented, many patients with generalized slowing, I'm sure that's part of the encephalopathy, focal ictal changes, and even non-convulsive status epilepticus has been documented in one patient with an overt psychosis. So they've kind of separated them, they split this, and then there's a bunch of people that put them into the category of encephalopathy. And here, obviously, there's not going to be the manifestations in the CSF. But this is obviously a pathobiological process of the brain developing over hours to days in the setting of this illness, which can manifest as a change in personality, behavior, and consciousness, which can be from mild delirium to, as we all know, a coma. There is no evidence of brain inflammation. There's no pleocytosis and no MRI changes. But there are other causes that could be ascribed to this particular process, and that is hypoxia, which is quite common in these patients, a happy hypoxics that we've seen, drugs of all the medications that we throw at them, toxins and metabolic derangements, as we know, those are common. Some patients also complain of long-standing headaches, and infrequently also dizziness can be a manifestation. Of the Wuhan patients that were initially reported, 51% of the patients develop an encephalopathy, especially when they had a severe respiratory illness. And most of those patients were quite ill. In the French study, that went up to 84% with neurological complications, but 69% with an encephalopathic picture. These guys had MRI changes that showed leptomeningeal enhancement and sometimes ischemic changes, but without any neurological fallout. And they also report in that same group that once patients had left the hospital, they seem to have developed a frontal dysexecutive syndrome, which we obviously might still see in the future. Then there's cases of an encephalopathy with imaging changes of acute necrotizing encephalopathy. And you see it here as a fulminant inflammatory change that is happening in bilateral thalami and the diencephalon with hemorrhagic transformation. And this we've seen and was one of the things that we were expecting to explode. And surprisingly, we haven't seen many reports since the original study that came out of this acute necrotizing encephalopathy. Of the pathological samples that were obtained both at autopsy and in other trials from other parts of the world, they have found viral particles in endothelial cells and neuronal tissue with edema, neuronal necrosis, and gliotic hyperplasia. In children with this condition, they seem to manifest with a seizure as the most common symptom. Other manifestations include an acute disseminated encephalomyelitis picture or just a pure myelitis. And as we know, acute disseminated encephalomyelitis, or ADEM, is a syndrome of multifocal inflammatory demyelination of the central nervous system. Usually, we would classify it as a post-infectious entity. Here, it's occurring as a para-infectious entity. The manifestations are usually focal neurological symptoms with with an encephalopathy. MRI changes are very striking, and CSFs may be normal with or without pleocytosis on occasions. The treatment generally would be immune modulation with IV steroids, plasma exchange, or intravenous immunoglobulin. There have also been isolated cases of myelitis, as long, extensive transverse myelitis patients that have been reported in the setting of COVID, almost mimicking those seen in neuromyelitis optica. Of the peripheral nervous system and muscle conditions that have been documented, there's the Guillain-Barré-like syndrome, which is very, very common according to the literature, but mainly case reports have been coming out, single case reports rather than large case series. And from the looks of things, these are really coincidental more than anything else. So they may be actually related to the virus infecting or the immune system reacting to the infection in the CNS, in the central nervous system. It's usually characterized by rapidly progressive symmetrical weakness of limbs with or without sensory symptom, and the hallmark being a global areflexia, but that may not always be the case. Of the different variants of Guillain-Barré syndrome that have been documented, the Miller-Fisher is quite common. Some manifestations of a bigger stuff like brainstem encephalitis have been reported in the literature. There have also been the paraparetic variant, which is just lower limb involvement. Some patient presents just with dysphagia, lower limb paresthesias, obviously the more advanced Guillain-Barré-like presentations with respiratory failure and severe dysautonomia. And then there have also been cases of muscle injury or myopathies. And the initial reports came out of Wuhan with just raised CKs, but there have also been reports of frank rhabdomyolysis in certain patients. And then the big elephant in the room, stroke. And this is one of those areas where I'm not sure that we all understand this entity very well. So there is definitely a growing incidence and evidence of literature that seems to be coming out of CoV-2 and cerebrovascular disease. And the first lot of data came out of Wuhan, Netherlands, and Italy, where they documented between a 2 to 7% risk of stroke and stroke-like events. Usually it occurs in the 60+ year age group. But they also make a very important point that in New York, in a 2-week period, they had 5 patients present. They were all under the age of 50 with no real risk factors. These patients, when you look at them in comparison to the year before, had a far higher frequency as compared to the normal rate, which is usually about 0.73 cases in a 2-week period in that part of the world. And all these patients seem to have had large vessel ischemic stroke, which is quite unique. And when they looked at them, most of them had quite significant findings on large vessels with thrombosis in the aorta, in the arch, with odd findings in the heart as well. In terms of the onset of the strokes, there seems to be a median of about 10 days into the illness, but it can range from 0 to 33 days after the onset of respiratory symptoms. There have been a variety of mechanisms that have been postulated. Of the one, they found in a couple of patients thrombosis in the great vessel, especially the aorta. Some patients have had small asymptomatic infarcts that have been documented purely on MRI when they went looking out for these patients by doing MRIs in the ICUs. And all of them seem to have occurred in the background with raised D-dimers or a pro-inflammatory state. And since then, obviously, there's been lots of talk about using low molecular weight heparin, and it's become standard routine to do that in our ICUs and in the management of our patients that'll end up in the hospital. The pathology seems to focus on the endothelial cells with activation of inflammation and thrombotic cascades, upregulation of tissue factor, release of microparticles, which then results in a massive surge of macrophage and monocytes, giving rise to the thrombocytopenia, the raised D-dimers, and raised CRP. But having said that, as we all know, in any acute infection, but in particular this one seems to also destabilize. The virus seems to have an endotheliitis effect, and with that it may destabilize established carotid plaques. With the acute infection, there may be an added atrial fibrillation developing, both due to the illness and due to the fact that we might be using inotropes. And this local endotheliitis, which is found in arteries and in veins, has been documented in all major systems: the kidney, the heart, bowel, and lungs. So it seems as though the whole system and the whole mechanism by which this could be happening is not entirely clear. And so we need to get a lot more data in terms of where we go with understanding how these events may occur. So I'm going to start wrapping up. I'm going to say that the initial hype with regards to this virus and the neurological manifestations have started fading quite significantly. And we know that the most important reason for the initial hype was most of the data that were collected was case reports and expedited reports, which basically are not peer reviewed and clearly don't give us a good handle of what's been going on with this illness. There have been overwhelming numbers, and so a lot of data is lost in the collation. There's incomplete reports, both of imaging, CSF, and other investigations that should have been done, like EEGs. And most importantly, there's been incomplete follow-up. So I think we still got a long way to go in fully understanding the manifestations and where it might land up. Most of the manifestations thus far appear to be either acute or para-infectious entities and the immune response to these infective entities. We still await a post-infectious phase, and one has to wonder whether that is coming or whether it will ever happen. And considering that we've obviously had amazing medical management, and so we've come to our scenario and where we've had a lot of experience from the global pandemic, where we find that there's a much lower mortality and morbidity. And this is probably due to the fact that we were guided by much of the mistakes that were made elsewhere in the globe. We were able to start using steroids very early. Remdesivir has been on our cards and we've been using it a lot. The IL-6 inhibitors really has been a game changer in the ICUs, and I'm sure the ICU guys will bear me out on this. Also, we have a very well-oiled medical service in our country. And most importantly, a lot of tertiary centers around our country offering ECMO services for those patients that really required extensive care in the setting of severe respiratory distress. And most importantly, I'd like to say a big thank you and a big shout out to all the frontline workers that have pulled us all through this amazing pandemic. Thank you. I'll open the floor to questions.
Thank you very much, Pradeep. If you'd like to, please type your questions so that I can read them to Pradeep. I'll appreciate it. Or you can unmute yourself. I think that we haven't put you all on mute at this stage. Try and see if you can unmute yourself. Pradeep, doesn't look like anyone wants to ask you a question except to say thank you.
Wow, that was a quick one then.
Yes, it was an absolutely good one. I'll just give it one last opportunity for anyone who wants to ask a question. If there aren't any questions, then we'll move on. Is that it? Okay, Pradeep, you get off lightly tonight. You've either explained it too well. Oh, here you go. Sandile would like to know, how bad is the dementia-like symptoms?
Okay, so that's a very good question. Thank you, Sandile. So I think of the many cases that I've seen, and especially in the elderly patient, I can't but say that the vast majority of them come in completely encephalopathic. And then when they start turning the corner with the appropriate treatment, which I'm not sure that I understand the management in most cases, but the steroids are there, the plasmacons are there, the Claxane is there, and then they turn and then they recover and they almost go back to their baseline. So I haven't seen anybody manifesting with a dementia-like syndrome since the onset of this pandemic. So I'm not sure that I can actually answer it by saying that they've seen any cases, but I can say for sure that the vast majority of the patients, besides experiencing ageusia and anosmia, definitely come in encephalopathic and very confused. And then the other thing that I've noticed, which I want to share with some people, and I'm sure most people have seen it as well, the patients are severely hypoxic, especially the elderly patients, saturations of 65% with the nasal cannula, and they're happy and they're talking to you, almost wondering why you're so excited and why you're so concerned about them. And yet after a few days they recover and it's like nothing happened to them. And you don't see this in the typical acute respiratory distress that we see with other hypoxic patients that seem to want to kill you and jumping around the bed and completely encephalopathic and aggressive. These patients are the happy hypoxics as they've described them. And I must say, I've seen that a lot of in this particular period.
Thank you, Pradeep. There was another question around, please comment on the report of MRI abnormalities of the brain post-COVID.
Post-COVID, I don't know that we've seen, I must say we've not had the opportunity to look at very many post-COVID MRIs. So when they were sick, we couldn't MRI them because of the COVID nature, and then MRI wouldn't want us to have any patients in the the MRI. Of the international data that seems to be coming out and the fact that patients are showing signs of small strokes but asymptomatic, again, the reports are few and far between. I don't know that we have a good understanding. There is a current trial going on and that's looking at low molecular weight haploids and looking at the outcome in these patients. And I'm sure there will be an MRI component to it where we will be able to answer the changes that may or may not manifest as a late stage complication of the virus.
Thank you, Pradeep. Right, if that's all, Pradeep, there's been lots of comments. I'm sure you can see them thanking you. And somebody even said it was an excellent lecture, and I think it was excellent too. Next Wednesday night, if you will join us again to the people online, where we'll be talking about whether there is COVID reinfection or not. So next Wednesday night at 6 o'clock, don't forget to register. And if you require to watch any of these videos, of which I must admit, Pradeep, I missed your first slide because I was so busy trying to host the meeting that I forgot to record. You can find it on Netcare YouTube lecture series, and you'll be able to download it. I apologize, Pradeep, for missing your first two slides, but thank you very much. It's been a really good talk, and we'll speak to you guys next week. And Pradeep, appreciate it.
Thank you. Thank you so much, Mandy. Bye, everyone.
Bye. Wat nog?